Today we'll learn about this problem which can occur during a routine phacoemulsification and cause problems to a operating surgeon. We'll also see why it occurs and discuss the issues related, and then we'll see this video. Intraoperative Floppy Iris Syndrome, or popularly which is known as IFIS, was first described and noted by John R. Campbell and David F. Chang, who noticed that certain cataract patients in their practice experienced following difficulties during phacoemulsification, which was iris billowing, progressive pupillary constriction, iris prolapse into the corneal incisions during surgery, and they found that tamsulosin, a concurrent treatment which the patients were taking for the management of their prostate issues, was a factor. Now, it was further investigated that there are other alpha-1 adrenergic antagonists or alpha blockers which can cause IFIS. So one of them, which is most popular, is tamsulosin. It is also known as Flomax as a brand name. Then we have irazosin, doxazosin, alfuzosin, and celodosin. These are medications used in prostate patients and also when patients have urinary stones, and may be used by gynecologists for their urinary symptoms of female patients. And these contribute the cause of IFIS. Now, why is IFIS important in ophthalmology? So IFIS has an association with few problems which it can cause during phacoemulsification, and the classic signs of iris billowing, that is the iris which is fluttering, pupillary constriction which is progressive during the surgery, and iris prolapsing out from the corneal incisions, and these three are collectively known as IFIS triad, and then these can potentially lead to iris trauma, posterior capsular tear, and vitreous loss. The above mentioned risk is introduced and may persist lifelong even after a single dose of alpha adrenergic blocker medication. Now this is very important because any patient who has received these medications even for a one day or one dose may keep on having the same risks for IFIS for the rest of the life. Now, when to anticipate IFIS? If we can elicit the history of concurrent or past use of alpha blockers, or there is a history of urinary or a prostate problem which was treated by oral medications if patient cannot recall the name and class of the medication used, or we can see poor pupil dilation with mydriatic drop instilled during a pre-op workup, and these are predictive of severe IFIS risk. Now, once we have that knowledge that the patient is prone to have this problem during surgery, how can we prevent that? So, first thing which can be done as a community or a healthcare provider awareness is that these medical persons who are prescribing alpha blockers be made aware that if a patient needs alpha blocker for long term and has a visual problem, then he should be having his visual problem attended by an ophthalmologist and managed before starting alpha blocker. Or it can be a choice of alpha blocker like alfuzosin, which is known to cause less effect in this situation. Apart from that, atropine 1% eye ointment 2 days prior to phacoemulsification or eye drop before surgery can cause less occurrence of IFIS. Per-op use of intracameral epinephrine and lignocaine is known to reduce the issues related to IFIS. So how to manage it? Use intracameral mydriatics, which is a combination of lignocaine with epinephrine. Using pupil expanding devices, which can be the expanding rings or the hooks. Meticulous placement or revision of corneal incisions if one finds that they are leaking and the iris is prolapsing through them. and very careful manipulations during the surgery. These things can help in managing IFIS, which can contribute to complications during the cataract surgery, and these complications can go way long in causing further problems. This is a patient which was planned for a routine cataract surgery having nuclear sclerosis grade 3 to 4 and aged about 72 years. He was taking such a medication for his prostate problem, and as is evident, the pupil is not nicely dilated even before we start the surgery. We can see that by the time the rhexis has been completed, the pupil is progressively getting smaller and smaller, and by the time the rhexis has been completed, we can appreciate that it is hardly 5 millimeter in size. The phacoemulsification was started, and as you'll see, the iris keeps on fluttering during the course of the surgery, and usually this is a problem, but as I'm trying to demonstrate in the surgery that a slow, deliberate and very calculated, meticulous approach to such case can lead us to a completion of safe surgery without use of any additional instrument or any expander or iris dilation rings. At this stage, I want you all to know that we have put in intracameral mydriatic solution, which consists of lignocaine and adrenaline solution as prepared by using preservative-free xylocaine, which is available as Xylocard injection. And the core important thing to remember and know is that the phacoemulsification has to be done in the central area only. If we go underneath the iris and try to trap or catch the nucleus pieces, it is going to cause an issue. We can see the iris fluttering badly, and it is even going into the wound also, and it is tricky to remove the cortex which is hidden underneath the meiotic iris. So an instrument is used to move away the iris tissue to visualize the cortex and so as to safely remove it in direct view so that capsule can be prevented from getting damaged. The iris is prolapsing out, so it was very important to not to entangle the iris in any way. The surgery has been completed, and with aid of viscoelastic material, the pupil has been managed to a reasonable size presently, but we can see all the time the fluid currents which cause the fluttering of the iris. This is the picture the next post-op day, and even then, in spite of a mydriatic, the pupillary dilatation is not very good. However, the cornea is clear and the patient had satisfactory 6/12 BCVA. Thank you.